Hi, I'm Roger Magulitz, Research Director at O'Reilly Media, and I'm here with Jordan Shlain, who is a doctor and has also started a company called HealthLoop based on patient need, which I thought, wow, that's great that you thought above it. I also, just as we're starting, I think interdisciplinary things coming together is what really drives innovation. So I'm really happy to see when stuff like this happens, is that you don't have to be a tech expert to build something.
And I'm not.
That's right, and you also maybe don't have to know about health to help with some health stuff. So why don't we just start with this little description of how you got to HealthLoop?
So practicing medicine, requires two people to sit in a room and have a conversation, as simple as that. And the problem is the denominator is the minute, or it's time. And you can't make more. and so because I have these constraints of time to listen to a story, and then once I listen to the story, I try to take that data, create metadata, which is a diagnosis, and then I have to come up with a treatment plan, and then I have to tell you what I think we should do, but it's really what you should do over the next period of time, and then you leave. And I hope you remembered everything I said. And I know that you're going to have questions later, so you will call me over the next couple days with a variety of questions that you maybe weren't clear on or you need clarification on. And you also won't know if you're progressing as fast as possible or in the middle, or most people know they're getting worse. So I had a patient who was in my office, and she had pneumonia, and I gave her antibiotics, and she was in her 60s, 70s, and I said, here's a prescription, and you should get better, but if you don't, call me, here's my cell phone. So I made it frictionless for her to get in touch with me, and 7 days later the phone rang, and it was the emergency room. And she was in respiratory distress, and they were putting her in the intensive care unit, and they weren't sure if she was going to make it. And I thought, why didn't she call me to tell me? She must have known she was doing worse, and then I thought, shame on me, I should have called her. But, statistically, 95% chance she's going to get better, so I can't call everybody. So then I thought, well, maybe she's never seen this pneumonia movie before. She didn't, and because she was sick and not feeling well, she wasn't thinking clearly, and, I wasn't giving her any day-to-day guidance or understanding how she was doing. So EMRs, electronic medical records, and PHRs, personal health records, both end in the letter R. They're records, and they tell you what happened. They don't tell you what's happening. So I endeavored to try to understand what was happening with my patients after they left. So I opened up a Microsoft Excel spreadsheet, and I created 3 columns, and I would call people that I was concerned about. I'd say, are you the same, are you better, are you worse than yesterday, globally? And that was my one question. I had a little bit of an algorithm. I would score a same or a better and a worse. Mm-hmm. And if you were doing better, I would move you down to category 2 and then to category 3, and then eventually I would want to get you off. But if you started going the other way, then I would want to see you again, because now I know how you were doing. And the interesting thing is if you have pneumonia and you give me a same, that's actually not good. I need to see a better in there. But you, because you're not worse, are feeling like that's okay. So again, it goes to this, people just are, they can only contextualize their moment in time. I have seen that movie many times, and I've seen all the possibility of endings. Those movies that have different endings. You can make up an ending. So I've just seen all the endings. So what HealthLoop, this idea that turned into a software became, was evidence-based medicine is what everybody talks about. The data informs the evidence. But there's no evidence for evidence-based medicine in clinical practice when you're dealing with an N of 1. Because that N of 1 may fall on either side of the bell curve where the meat of the evidence says this is what you should do. So you have to, they call it the art of medicine, kind of for a reason, because I've got to artistically take you as an individual, apply the evidence, but what starts to happen once you become, you've been doing this for a decade, is I get experience. And so I'm trying to recast experience-based medicine is more important and should inform evidence-based medicine than what's happening, which is the other way around. Mm-hmm. And furthermore, you're a human being. You care about yourself and you have preferences. You have a life, and we typically don't bake into the medical model your preferences for how you want this to play itself out. You may say, hey doc, I want to get better in 3 days. Give me like the nuclear antibiotic. Right? And then some people say, hey, look, I don't want that hardcore. Give me the lighter core. I don't care if it takes me 5 days. So I'm trying to bake into the world of preference-based medicine, experience-based medicine, and then you get on your iPhone or by email. So I write a prescription that says check your email, and you say, hey, doc, I checked my email. Okay, this is a prescription. This isn't for fun. So you would get an email and it would say, hey, Dr. Shlain wants to check in with you today. Couple things. Here's what you need to know today. A lot of people have these questions, and here's the FAQs for you today, and they're relevant to you today. And it's not like here's the FAQs for the next 2 months. So it's a little bite. Here's what you can do. Here's what you shouldn't do. And by the way, here's the things I asked you to do. Did you do them? So it's a dynamic checklist. And then, by the way, here's 3 multiple choice questions for you. How are you doing? Are you able to get up out of bed? Are you able to eat? Things that you can't sensorize. Mm-hmm. Now, we do take sensor data, and we have the capability to plug in whatever sensor, so we can take objective data and subjective data. And then what comes back to me, the doctor, is I'm sitting there, and I get this. I don't know if you can see this, is I will get an email that says, hey, you have. I don't know if we can see this, but it says you're following 12 patients. 1 of them requires your attention. 0 of them are of concern, and 10 of them are progressing as planned. Mm-hmm. So we've layered this experience-based medicine with this content where we mine the brains of doctors, nurses, receptionists, everybody in the chain of who you are going to deal with when you as an individual go in. So population data, the you are the you in population. But if I understand how all of my population is doing right now, I can get in front of bad things. Mm-hmm. EMRs can't get in front of bad things. They tell you when the bad thing happened.
Right.
And so I'm trying to re-architect, if you will, the design and flow of the patient experience and the physician experience. Mm-hmm. Because we have digitized an analog paper process into a digital paper process. So we have digital paper, but technology can do lots of cool things. And no one's applying true technology to the problem surface of medicine, which is really the doctor-patient relationship. Mm-hmm. Because ultimately, and there's trust. You trust me. I don't know if you trust your insurance company. I don't know if you trust your employer. I don't know but I know that you're probably going to calibrate me higher than most. And so if I ask you to do something, you'll probably do it. Mm-hmm. And so I'm really trying to get into the weeds of it. This is a hard problem. Nobody wants to go where the doctor and the patient are because it's so hard. What they want to do is they want to go around me. So everyone's trying to come up with solutions to bypass me and the patient. But the truth is, you're going to get a marginal incremental change unless you get me to be informed and you to participate in a collaborative narrative about your health. And so I'm going into I call it narrative-based medicine or contextual-based medicine. Mm-hmm. So that's kind of the...
Yeah, and it sounds like it fits in the precision medicine or it used to be personalized medicine in this.
Right.
So where are you in the development of HealthLoop? It's a startup. Is it funded?
I presented it at a white paper. I helped write a white paper called Reinventing Primary Care for a think tank in Washington, and some guy came up to me afterwards and he said, hey, you should turn that into a company. I said, I'm a doctor. So he said, I'm going to write a check. I'm going to help you build this. So fast forward, we've raised various amounts of money, and we are now piloting this in a number of medical practices.
Oh, great.
But the most exciting thing is that we have a large insurance company that has agreed to do something which has never been done before. And it's called, and we've kind of invented it, it's called pay for engagement. So what does that mean? It means that me as a doctor, I can get paid to enroll my patients on loops, these feedback loops, to help you understand. But I will only get paid if the patient actually checks in X percentage of time. So if I prescribe a loop and you don't check it, then I don't get paid extra. And now if I prescribe a prescription for you, I can't get paid for prescribing a pill. Mm-hmm. But what I don't know if you took it or not. Now, ultimately, it's in your best interest to take that pill, but some people don't take them. I mean, we have a huge compliance problem.
Right.
But we can now audit whether you're doing it, and I, for the first time, can know that you're not being compliant with this, and I can proactively call you. And hey, I see that, are you okay? Is everything all right? I see you're not checking in. Right, so then you can use the telephone for proactive phone calls versus all the reactive crap that comes into a doctor's office all day long.
Right. So how do you think you're set for scaling?
So we have a number of very large health systems. So the $2.7 trillion that our country spends on healthcare, 2.6, most of that dollars are dedicated to diagnosing and treating. There is $0 for follow-up. There never has been.
Right.
There are textbooks and evidence on how to diagnose, and there are textbooks and evidence on how to treat. There are no textbooks and evidence on what to do after that. Right? I call it a green field in a black hole because it would be interesting to do something, but you can get sucked in and die. So, but now with the Affordable Care Act and what's going on, everyone's trying to go, outcomes matter now. So that's follow-up. So now everyone's going, oh, we got to figure out how to follow people in a meaningful way that's meaningful to you and meaningful to everybody. So how do you get everybody to win? So we have a number of large healthcare systems that are looking at this as the tool to roll out to all their doctors, because they're going to get penalized if they get bad outcomes.
Right.
So they're not going to get paid. So these are self-insured, they're taking on risk. So they have to now manage risk very intelligently. And my whole thing is go to the doctor and the patient, and you can solve it there if you can get the doctor to buy in and the patient to buy in.
Right.
But trying to go around it and have other people engage with the patient, the trust factor isn't high, and that's why these things often don't work. I mean, Life Masters, which was one of the biggest disease management companies, billions of dollars failed.
Right.
So
one, thanks for stopping in
Yeah, sure.
here. And I have to say, I think we're seeing like what the future of healthcare is going to look like as far as the doctor-patient
I
relationship.
hope so. I mean, I'm just this little guy chugging along and trying to make a difference, and but it's resonating with people. People are. I mean, it's an obvious thing. Everybody wants to trust their doctor and have access to their doctor and feel like their doctor's in their pocket in some way, shape, or form. So I think I'm just tapping into common sense, and I think that we're trying to solve second and third order problems here. We should go to the act. We're trying to treat symptoms. I want to go to the problem.
Yeah.
And that's where I think I'm playing.
That sounds great.
And it's hard.
So thanks again for
Thank
your
you.
time.